Every 40 seconds, someone in the United States has a stroke. 1 in 4 adults will have a stroke in their lifetime. It's fast, frightening, and often life-changing, but can it be preventable? Welcome to the Health Exchange. I'm Dr. Jay Rutland, and on today's episode, we go inside the world of stroke care, from the emergency room to rehab, from the science to the deeply personal. I'm joined by a very good friend, Cris Medina, a neurointerventional nurse practitioner who works on the front lines of stroke response. Cris helps coordinate life-saving procedures that restore blood flow to the brain, and it'll help us understand both the urgency of stroke care and what happens after the emergency. Let's get started right now. Cris.
Yes.
You and I have known each other for probably, 10 years now.
Yeah.
I think.
Yeah, 10 years.
We met at Riverside Community Hospital, right?
Yep.
You were a nursing student.
I was, yeah. Yeah.
Wearing all that white.
I know. Awful uniform.
You remember that?
I do remember that. And you were a brand new attending.
I was.
Yeah.
I was scared out of my effing mind.
That's true.
When I first started. But you tended to bring a calmness, a funness in the intensive care unit that was absolutely necessary in the environment that we were in, because we saw a lot of pathology that was very severe.
Yeah. Your
training process at that hospital, what was it like? Were you like, did you think to yourself, wow, this is normal? Or did you think to yourself, man, I'm getting like really, really good experience?
Well, I think it's important to discuss that. I think you were absolutely the reason I got hired at that job. I don't even know if you know that or not.
I have no idea.
So you spoke to my nursing manager and said, hey, he would be a really good hire, but you didn't even know I was gunning for that ICU. The reason I was gunning for that ICU is because we saw so many disease pathology, and it was from cardiology, neuro, respiratory. We saw everything, and it was based upon a lower socioeconomic status, basically clientele.
Yeah.
And it catered to me. It appealed to me. That's the demographic that I like to serve and help. And it just kind of went with what I was looking for as a new nurse.
Was that Angela?
It was Angela. It was Angela.
Oh,
Yeah.
I don't even remember these things.
Yeah.
Like, that is so funny.
Yeah.
But it was definitely true. I mean, you definitely deserve to have the position, which you did get.
Thanks.
Do you think that your experience in the ICU then has led to what you're doing now?
Yeah, 100%. And I think it's good to discuss it. I was a nursing student, but I was coming from a very high level position as a paramedic. I was a critical care paramedic. And you were asking me questions about the ventilator that a nursing student would not typically know. And you were kind of like, wait a minute, how do you know what PEEP is? How do you know what assist control was?
Yeah.
And so that's kind of what established our friendship, and, the fact that we kind of had similar upbringings.
You as an EMT,
Yeah.
you as a nursing student, you working at RCH, which is like the busiest place on the face of the earth.
Yeah.
Did that lead and impact, what your decision is today to be back at that same hospital, now coordinating care for individuals that have stroke?
Yeah, I think it all came to fruition because I'm working in such a subspecialty in a high acuity setting of neurointerventional radiology that all of those patient vignettes that I was subjected to as a new nurse, as a nursing student, as a rapid response nurse, those all come into clutch when I'm making decisions now. So yes, it was definitely a big part of the indoctrination of the position I'm in now.
Look, you guys, we're going to get into stroke. I promise you we will. But I just want you guys to really understand that Cris and I grew up together in the hospital. I spent more time with Cris than I did with my kids, because I was just there all the time.
Yeah, it's true.
Like, I went to the hospital on Monday. Mo Byring couldn't come in Tuesday night, Wednesday night, or Thursday night.
So
And over time, I was like, man, we got to get somebody to cover call. So I just said, F it. And I just stayed in the hospital Monday until Friday.
But that's who you are, though.
Yeah.
You've done that your entire career. You say yes and kind of overextend yourself, spread yourself a little thin. You do.
So do you.
Well, that's why we get along and why we're here today.
That's why my hair's getting thin and why your hair's not thin.
Well, you know what? My hair's not thin. I have a full mop of head of hair up here.
Okay.
It's just covered up today. Yeah,
Okay.
yeah.
No, but I mean, I'm just saying, like, that place, Riverside Community Hospital, is such a special place because we had the opportunity to watch it, see what it was when we got there, which was a show.
Mm-hmm.
And then it got more organized.
Yep.
and it grew massively, and
Yeah.
you saw the different units. You saw the stroke unit get
Yeah.
developed.
Yep.
The new ICU get attached, right? The cardiac program got a little bit better.
Mhm.
We had residents that
Yep.
started to come in and make the hospital even more organized,
Yep.
elevating kind of everyone's awareness of what needed to happen for these patients.
Mhm.
And I think when you go through something like that, as an employee of the hospital, as an employee of a pulmonary critical care group, what I was at the time, it gets you to truly understand the importance of advancing your own career and educating yourself.
Yeah, and I don't think I would have changed a thing. Do you, looking back, would you have changed it? Would you have wanted a more organized or more chaotic upbringing in medicine? I personally, I thrived in the chaos. I think you did as well. It taught us very, very valuable, like I said, vignettes that we can apply into the critical care setting now. So I wouldn't change a thing.
I mean, it's so funny because for me, the time to be calm, like the time when I actually got a break from the chaos was when I had to intubate somebody or
Yeah.
put a chest tube in
Yeah.
somebody or
Yeah.
do something emergent
Yeah.
because like I had to like get organized, get everybody set, and just I got to take my time and do the procedure of what needed to be done. So when you are talking to patients, how do you explain stroke to them?
So I think it's good to speak in layman's terms. Not everybody is privy to medical terminology. So you have to look at stroke. You have to look at your brain as a busy city, and that busy city having a constant, steady flow of electricity. Well, the way that electricity gets delivered to the city is by these major power lines, okay, AKA the arteries that carry blood from your heart to your brain. Now, sometimes there's a disruption in that communication from the source of power to the city, and you get a blackout. That is typically a stroke. That's typically how a stroke would manifest. There's a temporary disruption in that flow of blood, which causes those cells in the brain to die, in essence. And we manifest that in different and various ways. It could be slurred speech, it could be unilateral weakness, it could be headache, it could be disruption in vision, things of that nature. So I kind of relate it to a city that has a power outage. Now, sometimes we can restore that power and things are running as they should. Other times we can't. And that's where it gets a little complicated.
He's exactly right. And when you think about stroke, one of the things that he mentioned is he mentioned all the types of symptoms that you can have. The reason that you have many different types of symptoms when we're talking about stroke is because as a result of your heart pumping blood up to the brain, right? And there's several different pipes that the blood can go through to basically service different parts of the brain. Your brain, this big organ up here, has a heavy responsibility and controls many things in your body. So it controls the way you move your arms, the way you move your legs. It controls your heartbeat. It controls your swallowing mechanism. It controls your vision, where you see, what side of the brain is seeing what, all of these things. And so based upon where that lack of blood flow is, you're going to have different symptoms, right?
Correct.
There are major arteries that go up to the brain, and we all know the names of them, right? We all know the anterior cerebral artery, the posterior cerebral artery,
Mm-hmm.
the communicating artery,
Mhm.
right? The vertebral artery. All of these arteries are, like you said, they're just power lines going to different parts of the brain
Yep.
and the brain stem.
Correct. Yeah, and the vertebral arteries supply blood to the posterior aspect of the brain, while the carotid arteries supply blood to the anterior portion of the brain. And then you have what's called, a lot of people know from anatomy, circle of Willis. Those two are able to communicate and keep a constant supply of blood to the tissue of the brain. And so sometimes there's a disruption in that, but you have other mechanisms in place to sometimes supply blood to the area that has a lack, a deficiency in that blood supply.
And because your cells in your brain are always working, if they do not get blood flow for seconds, they immediately start.
Highly responsive to that deficiency in blood flow.
So there are two main types of stroke. What are they?
Ischemic, which is characterized by an embolic stroke, or a hemorrhagic stroke, more prevalence with the embolic type stroke. So something coming from a clot. So if you have like a AFib, is one of those conditions in the heart where the atria poorly functions and you can develop a clot. That clot can shower up to the brain via your internal carotid arteries, your external carotid arteries as well. And it can cause an issue. It can cause a blockage in that flow of blood.
Yeah, so you basically have just arteries are just pipes.
Yep.
They're just carrying blood up to the brain. And if those pipes are blocked, like you're going to have a stroke.
Mhm.
And what Chris was mentioning is he said ischemic stroke is the most common type of stroke, which is the obstructing stroke. That's the one where you block the artery and the blood flow doesn't get there. I think it's like 71% of the time or something like that.
Yeah.
Something
Yeah.
like that. you're going to have an ischemic stroke. What a hemorrhagic stroke is when one of those arteries in your brain bursts,
Correct.
right? And when that artery in your brain bursts, right, depending on how big that rupture is, right, that blood is going to splash on your brain cells. That artery doesn't get the blood to that area, and you lose some perfusion there.
Correct.
Now, if it's a huge burst, that's a problem, because not only do you have the swelling secondary to the blood touching those brain cells, but you also have that lack of blood flow, and you have a skull. You only have so much space in here. So if that blood gets too big, that blood flow gets too big in that brain, it's going to put pressure on other parts of your brain, and you have a herniated brain, which is a problem.
Correct. And I think you touched on that when you said the skull, the cavity only has a certain amount of space for certain things. You have your brain tissue, cerebrospinal fluid, and blood. But when that blood leaves your vasculature, it's now creating space that is not existent. So it starts to press on different various areas of the brain tissue, and it starts to, maybe you have a shift, a midline shift. More, I guess, devastating would be you have herniation, tentorial herniation, where you're herniating brain tissue out of the foramen magnum. And that is a big problem.
I mean, it's an absolutely devastating problem. I have never shared this story on any platform ever in my life. So this was probably maybe 12 or 13 years ago. So when I was in high school, I lived with my mom's twin and her husband, Uncle Don. And then I lived with my cousin Eva, their daughter. And Uncle Don and I, when I was growing up as a kid, he was very silent. We didn't really relate with one another. No big deal. That was Uncle Don. But when my mom moved to San Francisco, my mom was like, well, if you want to stay in Sacramento, you got to live with Ginger and Don. I was like, well, whatever. I was playing hoop. Like, I'll live with Ginger and Don. Fine, no problem. So then I spent a lot of time with my Uncle Don. And Uncle Don and I shared an interest in basketball, NBA basketball. This is like peak Jordan, Allen Iverson. It's like 1996.
This is in the thick of it.
This is in the thick of it. He loved Allen Iverson. I loved Allen Iverson. We started watching basketball, and he would take me to all my basketball practices. And I was a good basketball player, and he would go to all my basketball games, and he would make sure I was fed. He would give me money every week. He would make sure I had everything I ever needed. He was like probably the first consistent like father figure I had in my life.
Wow.
When I was a second year, I think, medical student, I get a phone call from my aunt. And the phone call is my Uncle Don had a hemorrhagic stroke, posterior stroke. Posterior part of the brain, your cerebellum is there, so that's balance, right? So it's like kind of like where you are in space and your proprioception. Like, I shit you not, I thought he was dead. I thought he was going to die.
Yeah.
And I saw the degree of bleeding, and that was that was probably like the first, after my grandfather dying, that was the first like kind of major event of somebody that like meant something to me.
Yeah.
And I thought I was going to die. My cousin Eva did such a fantastic job making sure that he was appropriately cared for post-stroke. And it was a hypertensive hemorrhage because he had high blood pressure. And he's alive. He can't eat anymore. He's got a feeding tube, lives in a wheelchair, can't walk. But his personality is kind of still there, so we still kind of talk to him. And, he was on the vent for a long time and did have some recovery. But about 2 years ago, he had a setback. And again, I thought he was going to die. So much so that I actually wrote a tribute. I'm going to read it.
Okay.
So again, this is when I thought he was going to pass. But I think it's important to say things to people when they're still alive.
Yeah.
So they know. It's titled Dawn, and I wrote it November 18th, 2023 at 10:30 a.m. Said, in high school, my mother moved to San Francisco, and being the teenager I wanted to stay in Sacramento. I did. I ended up moving in with my mom's twin and her husband, my Uncle Don. I wasn't really close with him. I played basketball all the time. He read books. Their house was full of them. We got closer. I got closer to staying in those books. He got closer to basketball. He took me to every game and never missed one. I introduced him to Iverson, Jordan, and Pippen. He introduced me to academics. Without him, I wouldn't be here. About 15 years ago, he had a huge posterior hemorrhagic stroke. And I thought he was going to die. He didn't. He lived on, wheelchair bound and with a peg tube, but he was happy. Now another bleed, which means less brain to come back to, which means a transition to the next stage of life, death. I know it's natural. I know he had a full life, but there was a time where I thought my life was full without interacting with him. Boy, was I wrong. Thanks, Don, for teaching me how to truly read and comprehend. Thanks for being at every basketball game. Thanks for being a part of my complete life. Your physical presence will be missed, but your lessons have been passed down to my children.
Wow.
I love you, and tell Granddad I said hello. He's still alive, kicking, loving it.
That's really powerful. What actually prompted you to write that, though? What did you...
I think at that time,
Mm-hmm.
when he had the rebleed, this is after training. I'm a full-on attending.
Yeah.
9 years into it. I had seen it so much in the intensive care unit that I kind of, you make these leaps and these assumptions because...
But they come from somewhere. They do.
They do. They come from experience.
They do, yeah.
And I just felt like I needed to express my feelings towards probably the first real father figure, other than my grandfather.
Sure.
But the first real daily father figure I had ever had in my life. And as an ICU doc that deals with all this stuff, I do a pretty good job keeping my emotions in check.
Yeah.
But the way that I deal with some of the personal thoughts is I just write.
Yeah.
And I got all these notes in my phone, all these things. And again, I've never shared this story with anybody. This is like new. But I just felt like it makes sense since we're talking about stroke. Because for me, like, I always ask myself, like, what were his first symptoms?
Mm-hmm.
Right? And his first symptoms were headache. Right? Because a posterior stroke is one of those strokes where you can actually recover from those.
Yeah.
If you reach them like pretty quickly.
And the symptoms are a little less vague, actually, than anterior stroke.
Yeah.
So those are the ones where you can have like mild visual disturbances, maybe it's a little blurred vision, and people tend to like rub their eyes and think, oh, well, maybe I took a long nap and, my vision's a little bit off. The posterior strokes are the ones that are very, very vague. They are not like MCA, a middle cerebral artery stroke, where you see complete loss of functionality on one side of your body and your face is drooping. Those are a little bit more recognizable.
Yeah.
So, yeah.
And no, nobody recognizes symptoms, right? I mean, he passed out, ended up in the hospital, and I remember getting these phone calls, and then I was a baby med student. Like, I didn't really know much. I could read a CT scan a little bit. I could see the blood because all blood is on a CT scan is white.
White, yep.
But what I saw was a devastating anatomical displacement and destruction of the posterior aspect of his brain.
Sure.
And I didn't know what to make of it when I was a baby medical student, right? I had no idea what to make of it. But I can tell you that the person that saved his life, for as many fights as I got in with my cousin, and I did, her care to make certain that he was getting everything that he needed in terms of rehab, in terms of, nursing home stays, getting the right nutrition, getting the right occupational therapist. It was unbelievable. She is the single reason as to why he's alive today, right?
It's amazing.
Don's like stroke just like really, really affected me. Like, I learned a lot about stroke that year because of it. And this is something that you see like on a daily basis. So like, what would you say, what do you want them to know for symptoms of stroke?
Don't ignore symptoms. Time is absolutely of the essence. We say it in medicine all the time. Time is brain. And your quick recognition of these symptoms is paramount to the preservation of that cerebral tissue. So if you are experiencing any numbness, any visual disturbances, word finding difficulties, don't ignore them and think, oh, it may get better, because I hear that all the time. Some of these medications that we administer, we have a time-sensitive frame that we have to stay within. If it goes beyond 4.5 hours, I can no longer give the medication that could potentially break up the clot that's producing all of these ailments. So be very, very fast, and we'll talk about what be fast stands for, but it's true. We have to be fast in recognizing these symptoms.
And the medication you're talking about that you give within 4.5 hours of having symptoms is tenecteplase.
TNK.
So patients having symptoms at home,
Mhm.
somebody's rushing them to the hospital.
Correct.
When they hit that ER door, what should happen? What should they say? What are they going to go through?
Yeah, so they can come into the hospital by one of two ways. They can come in by private auto. So somebody from their family drives them into the hospital and they present through triage. We have nurses in triage, and we also have PAs and NPs in triage that can recognize some of these symptoms, and they will activate a code stroke. The other way is if they call 911 and they're brought in by ambulance, those paramedics actually communicate to the nurses at the hospital via radio any symptoms that are alluding to a stroke. So they can come in by two mechanisms. Once that code stroke is activated, that prompts my presence there at the patient's bedside. From then, I start my assessment using the NIH stroke scale. So we do a list of things, and the way that is it's cumulative. So the higher the number on the NIH stroke scale, basically the more debilitating factors I've encountered. And so we're tallying it up. So for maybe slurred speech, that's a point right there. Maybe 2 points if you can't, intelligibly understand what they're saying. They are so dysarthric. That's a 2. So it just kind of tallies up from there. Then I start to ask them questions that would exclude them from being a candidate for TNK. Have they had a recent stroke within the past 3 months? Have they had a head injury? Have they had any cancerous lesions in the brain? Things that would rule them out for getting the TNK. Once they are ruled in and they're within that 4.5-hour window, we take them quickly to CT scan, because the number one thing I want to see on a head CT is that there's no blood in the brain. If they're bleeding, all bets are off. We can't give them TNK. But if they're within that 4.5-hour window, they have debilitating symptoms, and there's a negative head CT, then we can give the TNK. And we try to give it in 20 minutes or less.
And if, say, for example, if a patient gets to the hospital within 4.5 hours and they can't get TNK because, I don't know, say there's a malignancy.
Okay.
Or say there's some other thing. I don't know. Are there other options for them after you've ruled out an acute bleed? Are there other options?
Yeah, there is. So that would be a situation, or let's just say they had the symptoms, but they're now beyond the 4.5-hour window, but less than 24 hours, we can do something called a mechanical thrombectomy. I work for a neurointerventional radiologist, and he's the one who performs these. So I just help coordinate these procedures. I recognize the symptoms, activate a code fast. And so what that means is we'll bring them down to the NIR suite where we have fluoroscopy and different imaging available. Then we prep the patient for the mechanical thrombectomy. What that entails is accessing the groin, going all the way up past the heart, basically kind of scooting our way through the vessels. And we make our way to the occlusion where we can mechanically remove the the insulting occlusion that is causing all of these debilitating symptoms.
And that's a pretty successful procedure, yeah?
It's a pretty successful procedure, and the benefit highly outweighs the risk. Of course, with any procedure in the hospital, there's always associated risk, infection, bleeding. We're working with the vessels, so dissection. We talk to the patients about that if we can, if they're consentable, and we talk to them about these. But again, the benefit highly outweighs the risk.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question: what question should I ask my doctor if I'm prescribed medication after a stroke? This is a great question. Here's the thing. You first want to ask your doctor, what kind of stroke did you have? Was it a hemorrhagic stroke where there was blood? Was it an ischemic stroke where there was lack of blood flow? Then you want to ask, how do my medications actually act? Am I on anticoagulation, which thins your blood? Am I on antiplatelet therapy, which inhibits your platelets from clogging up holes? Am I on medications to lower my cholesterol? Am I on medications to lower my blood pressure? This is going to help you understand the side effects of said medications. Then you can go into the side effects. If I'm playing a contact sport and I'm on anticoagulation, I may bleed. These are the types of questions you need to ask your physician after you have had a stroke. If you have a question, email us at healthexchangepodcast@gmail.com. That's the buzz. Thanks again to BuzzRx. Look up your medications on buzzrx.com or the app to see how much you can save. Now, once you go through the acute stroke event, Somebody's had the stroke, they receive tenecteplase, they get a mechanical thrombectomy. It's now up to us to look at the patient's risk factors and try to lower their risk, right?
Yes.
What kinds of things should we be looking for?
Yeah, that's a good point. I feel like there's a lot of modifiable risk factors and non-modifiable risk factors. Some of the modifiable risk factors, like one that stands out is smoking. Smoking, and as a pulmonologist, is one of the biggest modifiable risk factors and prevents so many different various diseases. But smoking is number one. You want to eliminate those things. Sedentary lifestyle, exercise, diet, things that we can modify on our own, we should be absolutely doing. And things that are unmodifiable are things like our genetics. You're an African American man, I'm a Mexican man. Those genetics are just unmodifiable. We are at a higher predisposition to things like diabetes, cholesterol issues, heart issues. We're at a higher risk of stroke. Those are unmodifiable. But I think we should do everything we can to modify what we can modify.
And so when we think about those risk factors, one of the things that I think is so important, like you said, that high blood pressure,
Oh, yeah.
that hypertension.
Yep.
That's something that we need to assess and treat because hypertension increases your risk of that hemorrhagic stroke, right?
That's the number one cause of it. Yeah, it's definitely a silent killer. There's so many patients that walk around on a day-to-day basis completely asymptomatic. They're without symptoms. They go and get their blood pressure checked and it's 180 over 120. Or if they finally start to develop symptoms of hypertension, they have tinnitus, maybe some blurred vision, maybe they're having TIAs. They've been dealing with this hypertension for years silently. That's why it's so important to get regular checkups. You can buy for $20 on Amazon a home blood pressure kit and, do self-checks at home. Be very aware of your vital signs, especially your blood pressure, since it is the leading cause of stroke.
100%. I mean, I really feel like there are so many times in clinic where I hear these scenarios where patients will have blood pressures like 150, 160 over 95. And some clinicians will be like, just go lose weight or
Yeah.
don't do this or that. And when I look at those individuals and I hear about those scenarios, I just kind of cringe. 'Cause
Yeah.
I'm like, that person's 71 years old. They're Black. They've actually gained 60 pounds over the last 2 or 3 years. Like,
Mhm.
this is somebody where we really we gotta exercise is extremely important. Diet is extremely important. But right now they need a medication to control that blood pressure in
Absolutely.
addition to that exercise and diet because we
Correct.
gotta lower that risk for that stroke.
Yeah, you gotta lower that, and then the other thing too is cholesterol. We have to modify what we can modify, but if there's things that are out of our realm of modification, that's what we turn to our primary care providers for. Cholesterol, blood pressure, aspirin, things that are putting you at a less risk factor for these strokes.
And one of the things I think that's important is once you've gone through the acute events, you're modifying the risk factors as you should. And how these patients that have had significant strokes, if they've had any loss of function or any loss of brain, they're going to have some loss of function. They got to go through extensive rehab.
Extensive rehab.
Tell me what
Extensive.
that's like.
Yeah, so depending on their degree of disability, they will work with potentially speech pathologists to get them to strengthen and redevelop the muscles that are required for swallowing, for speaking, even phonating, just making speech that will require rehabilitation. Occupational therapy, these people that help with your day-to-day activities of daily living, brushing your teeth, putting on deodorant, things that we take for granted. They are going to help to reorganize and rehabilitate your muscles so you have better coordination, you can strengthen, and finally focus in on things that you can, rehab from this stroke.
When you guys think about stroke, one of the muscles that goes really quickly is your ability to swallow, which requires like so many different muscles. And when individuals have a stroke, one of the things that they can do is when they swallow food or when they swallow liquid, they don't close the cap that goes over their vocal cords. And so that cap stays open, and then food particles and fluid can get right into your lungs.
Yeah.
And that causes a certain amount of inflammation that can lead to an activation of the inflammatory response in your lung. We call it aspiration related acute lung syndrome. Some people will call it aspiration pneumonia, but that's one of the consequences of individuals having an ischemic stroke or even a hemorrhagic stroke is that. And that's something that you really got to pay attention to post-stroke in these individuals, is their ability to eat, their ability to swallow, because you might have to modify that. Like my Uncle Don has a peg tube, which is a feeding tube directly in his stomach. He can't eat anything anymore because he swallows food and liquid directly into his lung, because those muscles just aren't strong enough, or those muscles might be strong enough, but the nerves that connect to those muscles are no longer active because of the stroke that he had. So that's something that you have to think about as well.
Yeah, it's a good point, and we do our best to try and rehabilitate these muscles, but there is a very real reality that potentially they will never recover, and you have to mitigate those risks. Like your Uncle Don, he has a feeding tube. He's beyond repairing those muscles that cause him to swallow, and it puts him at a higher risk of aspiration.
And, one of the things that sucks about stroke is when a young individual has a stroke, their organs may live on, their heart, their lungs, their kidneys, their liver, but their brain is gone. So they can be in this situation where they can't get up, walk, talk, do anything.
Yeah.
And they're just stuck in a corner.
Yeah, it's very sad.
It's very sad. I mean, we used to go to, and you did it. Remember, we would go to long-term acute care facilities.
Yeah.
And long-term acute care facilities are full of individuals that have had significant strokes.
And you would assume everybody's 80 years and beyond, but you see people that are 35 and 40 years old that were thriving members of society who were stricken with a debilitating stroke, and now they are bedbound for life.
For life.
For life.
And not only bedbound, it's not about being bedbound. It's bedbound and not an official part of society any longer.
Mhm.
Like, they're not doing anything. One of my wife's friends during the pandemic had a respiratory illness and had a brainstem stroke. When you have a brainstem stroke, your brainstem is the part of the brain, it's in between the brain and the rest of your body, that is responsible for relaying information. It's
Mhm.
like a satellite, just relays information, a lot of information. When your brainstem dies off, no information gets relayed. So what does that mean? That means that you are fully conscious of what's happening. You have the same mind that you have right now, but you can't talk, can't walk, you can't control your bodily functions, you can't do anything, and you know about it.
Yeah.
And these individuals, I feel very sorry for.
It's devastating.
And it's so important to recognize those symptoms of stroke for that reason, because of the cognitive impact, the emotional impact that it can have on family members.
Everybody's affected by it. And by no means are we here to fearmonger stroke. We're just here to create awareness that this can have a ripple effect that's beyond the stroke victim. It goes into the family. It goes into the workplace. Everybody knows somebody who's been affected by a devastating stroke.
So, again, the number one risk factors you mentioned, you said smoking, diabetes,
Hypertension.
high blood pressure, right?
Yeah.
High cholesterol,
High cholesterol.
atrial fibrillation.
Yeah. AFib.
Yeah, so, atrial fibrillation, you guys, again, it's an abnormal rhythm of the heart. You've got 4 chambers to your heart. One of the chambers, called the left atrium, sometimes that left atrium can be so large that blood can pool. And when blood pools, it coagulates. And when it coagulates, that's when you have clots, and those clots can just break off and go right up to the brain. You also have individuals that can have what's called a patent foraminal valley, which was the space or the hole in the heart between the right side of the heart and the left side of the heart that connected to the placenta. So when mom was raising baby within the belly, the mom's oxygenated blood would feed the baby so the baby could grow. And when you're born and you cry, that foraminal valley is supposed to close. But if it doesn't, we call it persistent. And so people have what's called a patent foraminal valley, and that hole stays open. So if you have a clot on the right side of your heart, say you got a DVT, a deep vein thrombosis, right, which is just a blood clot in your leg. If a piece of it broke off and traveled up, it could go right through that hole to the other side of the heart, right up to your brain. These are important things to consider
For sure.
and think about in terms of your risk factors.
Absolutely.
So, what's the future for stroke management?
Yeah, I think it's great to look at the future of stroke management while also looking at the past. and recognize that in the past, we didn't have mechanical thrombectomy. We didn't have tenactoplace. We've evolved and we're continually evolving. And what's on the forefront now is something incredible because it ties into something that I previously did as a critical care paramedic. But there are paramedic agencies, ambulance agencies that are equipped now on their ambulance. They're called MSU, mobile stroke units, and they have mobile CT scanning capabilities. And so the paramedics will respond to a person's home, find them with stroke-like symptoms. They're able to do a quick CT scan and transmit those readings to a radiologist that can say, hey, there's no blood, go ahead and give the TNK. And the paramedic could administer that because, again, remember, time is brain. So the quickest that we can administer that medication and intervene, the better outcome that they're going to have.
That's amazing.
Yeah, it's incredible. I'm very excited to get more of the recognition to stroke and prevention and where we're going with the evolution of stroke.
I wouldn't be a podcaster if I didn't say the 2 letters AI.
Yeah.
What about AI in stroke?
Yeah, I think AI is going to be a great addition to stroke. It's already proving to be a great addition to stroke. But I think, to err is human. And I feel that there are always the cases that we read about where a radiologist may have missed a reading. There's a lot of vessels that you have to cover in a quick fashion. So you're only human. And so, yeah, I think AI is going to be a great addition to stroke recognition, to vessel recognition, and the management of stroke. Yeah.
The wearables and smart devices, you think they have a role?
I do. So, there are smart watches that can recognize abnormal heart rhythms. So if you get a notification, a lot of them have the tracking. So you get a notification like, hey, I sensed something abnormal. I think that should prompt immediate intervention and immediate evaluation, because if you are in a new onset AFib, you are very, very susceptible to, like you had mentioned earlier, developing a clot that could break off and shower upstream into the brain. So yeah, I think there's a place for everything. And if it's going to benefit somebody, I think we should do it.
So earlier we polled the audience
Mhm.
and we wanted to know who has questions on stroke. What questions do you have?
Oh, great. Yeah.
One of the first questions that we received was, if I have signs of a stroke, should I call 911 immediately?
Yeah, immediately. Time equals brain. So early recognition equals early intervention. So calling 911 is of the utmost important. You will get dispatched an EMT and a paramedic in the fire department who are trained to recognize these signs and symptoms of a stroke and can expeditiously bring you to the emergency room for prompt intervention. So absolutely.
I know some of these, but you know more than me with the experience that you have. So if someone has a stroke,
Mhm.
can they ever go back to normal?
Yes, they absolutely can. With that early intervention, I think it's good to understand that you can have functionality be restored with these interventions like a mechanical thrombectomy, like the administration of a thrombolytic. But we also have to realize that we hope for that, but that's not always the case. And you could be left with a disablement of some sort.
Young people can have strokes too, right?
They can. I see it all the time. Pediatrics can have strokes. Absolutely.
If my mom or my dad had a stroke, am I more likely to have a stroke?
Yeah, you are genetically predispositioned based off of your relatives, your first degree relatives. So if you have a mom, a father that has suffered a stroke, then yeah, I would say you are at a genetic predisposition and a higher incidence of stroke.
Look, I really appreciate a good friend of mine, Chris, coming onto the show today. At the end of the show, we always discuss a positive pulse. I think it's something that we put out there in the health industry that I think is important to share, because there's lots of positive experiences from our industry. And so Chris has a positive pulse for us, and I think it's his turn to share it.
I had a 42-year-old female. She was a mother of 3, stay-at-home mom. She came in by ambulance. She had one of her children who was 14 call 911 because she was in the kitchen cooking and she completely collapsed to the floor. She had lost complete functionality of the left side of her body and she wasn't able to speak. She was rushed into the ER. I arrived to the bedside. She was looking at me. She was able to follow commands with the right side of her body. The left side was completely flaccid. She wasn't able to speak. There was tears coming out of her eyes. It was very, very troubling to see. The daughter had rode in the ambulance. She was crying. She was upset. But ultimately, there's a job that needs to be done. I had to quickly assess her, rule her in or rule her out for the TNK, as we spoke about earlier. Turns out she was a candidate for TNK. We administered the TNK within about 10 minutes. The way our brains are wired is because the occlusion was on the right side, the left side had the disability. So we took her down. He performed the mechanical thrombectomy. Within about 4 hours, she was speaking, she was moving the left side of her body, she had regained functionality. We've kept in contact with her, and she has a complete restoration of functionality. There's no disablement post mechanical thrombectomy. So that really stands out. She was so grateful to us, and because her child, of course, she collapsed, but she recognized these symptoms right away. She called 911. She got to the emergency room in a timely manner. We were able to give her the tenacticlase. We were able to do the mechanical thrombectomy, and now she goes back to being a mom of 3. Her husband is a truck driver. He drives all the way across country, so he's never home. Think about the effects that would have had on that family. She's the primary caregiver for these 3 kids, and now she's able to go back to being a mom and, being their primary care provider.
And not only that, but that 14-year-old child of hers that recognized it,
Yeah.
and that got her the attention that she required to be able to become, fully back to normal. That's amazing. But the second thing that I see from that story is that 14-year-old is going to carry that story and that experience with healthcare in a very positive way.
Yeah.
And will probably likely contribute to what we do on a daily basis in the future.
Yep.
Whether that person becomes, an RT, a nurse, a doctor, something that is extremely important in our healthcare industry.
Yeah, absolutely.
And I think, positive stories like that need to be told more, because all we read about and hear about on Instagram and Facebook and Snapface or whatever, like all we hear about are these negative stories.
Yeah.
Or this happened and they couldn't do anything, or that happened. And like stories like that are just so uplifting and powerful.
They deserve the notoriety.
They do. They do. And inspire just a generation of people to continue to help people.
Yeah,
and
absolutely.
That's a positive thing.
I do too.
Thanks for coming on.
Yeah, absolutely. Thank you for having me.
Really appreciate it. I know you're going to be on for a few more.
Yeah.
We love talking about stories like this. If there's something you want to hear, let us know. If there is a pathophysiology that you're curious about, let us know. We'll talk about it.
You can find me on Instagram or TikTok. My username is Cris the NP without an H. So it's CRIS_the_NP.
You guys can find us obviously on Instagram at the Health Exchange Podcast. We're on TikTok at the Health Exchange Podcast. You can get us wherever you get your podcasts. We're on every Thursday at 6 a.m. Pacific, 9 a.m. Eastern. Find us on YouTube. Find us at all those places. We'll see you next time. Thanks for joining the Health Exchange Podcast. Take care.